Morning, everyone. Welcome to the lecture on drugs of abuse. As I said in class, this is a bonus lecture along with the supplements. The content on this won't be very significant. I'll ask a handful of questions, 5 to 10 questions, and they'll be fairly straightforward, and I'll kind of tell you what I'm looking for. There's a lot of things I talk about that are social related and just points of interest about drugs of abuse in general. So anyway, enjoy it for what it is, and here we go. So there are three main categories I think of when it comes to drugs of abuse. There's your traditional, which I would say, in quotation marks. So traditional I would define as, things that people think of when they think of drug abuse. They think of heroin and cocaine and some of those really standard, like quote unquote, hard drugs. But just as important are prescription drug abuse, and certainly that's you can abuse things that are used for therapeutic purposes. Designer and synthetic drugs as well are kind of a new emerging thing that's happened over the past, I don't know, probably decade or so. We started seeing stuff come up, and it's just people basically becoming clandestine chemists and altering molecules and trying to put up new products that are slightly different than existing things, but are still going to cause the same physiologic effects. Historically, the DEA's had difficulty with the designer synthetic component just because there's so much legal red tape around assigning restrictions to certain drugs. Technically, you have to assign them to a molecule, but there's been some legal changes now that they can be more broad. But early, it was like any alteration to an illegal molecule was automatically not classified as a Control 1 substance anymore. It was not classified at all. So they were staying ahead of the DEA, and the DEA couldn't pass legislation fast enough to or legislation couldn't get passed fast enough for the DEA to be able to enforce some of this stuff. So anyway, lots of different odd stuff about these designer and synthetics, and I'm not going to talk about them a ton. I've got a couple slides on them later. We'll talk about what the main ones are and what they kind of are derived from and what the idea is behind them. But certainly the sky's the limit when it comes to that kind of stuff. I think people associate drugs of abuse with affecting people of low socioeconomic status, but really statistics show that they affect pretty much anyone from white collar, blue collar. There's no real population that's free from substance abuse. Every population has a percentage, and pretty much an equal percentage of people that tend to fall victim to substance abuse and addiction. There are a lot of different substances out there that do a lot of different things, but essentially the end goal is all pretty much the same. People are trying to alter their state of minds. And basically, when you break down how drugs of abuse work on a physiologic scale, you're looking at dopamine as the reward pathway. And pretty much everything flows through there. So they might do it differently, and they might affect other systems at the same time. But at the end of the day, drugs of abuse are going to cause a reward system. They're going to stimulate your natural body's reward system, right? So they're going to cause a flooding of dopamine, and usually this is done at much higher levels than standard, or I would say the ways that our body are designed to use the dopamine system. So for example, if you eat a meal, you're supposed to feel good about that because you need to eat to survive, right? So eating should be enjoyable. Same thing with like sex. Reproducing should be enjoyable because we need to reproduce to continue our lineage and our species, and that's something that is a natural part of how the brain's designed. And when it comes to drugs of abuse, it's manipulating that system, and there's a variety of ways you can do that, but when you break them all down to the core, that's pretty much what you're looking at. All right, some general effects of drugs of abuse. You've got physical dependence and psychological addiction. So I always like to separate these two out. Physical dependence being the dependence on the drug itself. So you can get physically dependent on a lot of things and not necessarily be addicted to them. So I don't like when people say, oh, I'm addicted to whatever. I've heard, what's a good one? I'm thinking of an example. Oh, Afrin, like Afrin nasal spray, so oxymetazoline nasal spray. I've heard a lot of people are like, oh, you can get addicted to Afrin. You can't really, I don't think people really get much of a psychological addiction to Afrin because it doesn't really, I mean, maybe they feel good when they can breathe, I don't know, but it doesn't really have that dopamine pathway associated with it. What it does have is if you overuse it, you get rebound congestion, and so you become physically dependent on it to the point where you can't breathe through your nose unless you use it. That's more of a physical dependence. More of a common one I think you can think of is, and you could associate caffeine with maybe having some psychological components to it too. But from a physical dependent point, caffeine, if you drink a lot of caffeine on a daily basis and you don't, you can get really bad rebound headaches because your body's not used to having if your body's used to having a fairly potent vasoconstrictor on board fairly frequently, and in large doses, and all of a sudden you cut it off, it's going to rebound and you're going to get vasodilation, and that can cause headaches. So just some examples of physical dependence, and certainly drugs of abuse are all associated with this too. The flip side of that is tolerance builds up as well. So you need to use more to develop the same amount. And oftentimes if you read stories about people's experiences with drugs like heroin or other opioids, basically they get high the first couple times, and then every time after that they're just trying to replicate that, and it gets harder and harder to do that, to the point where they're just using the drugs so that they can feel normal on a day-to-day basis, so they can get through their day. So it becomes almost like a functional component of your life at that point. Medical, certain drugs of abuse can cause brain damage. Some are directly neurotoxic. Infectious disease risk, usually due to the routes that people are administering them. So intravenous obviously is going to have problems when it comes to not using sterile technique, not using clean needles, things like that. Mental illness is often linked to drugs of abuse. Now, it's kind of like a chicken and the egg type thing. What came first? Was the person mentally ill and they used drugs of abuse or they started abusing drugs to combat the symptoms of their mental illness, or did they start using drugs of abuse? I should just say start abusing drugs, excuse me. So they start abusing drugs, and then they end up with some sort of a mental illness on top of that. So both cases are presented in literature, and both are feasible things, and they're treated pretty much the same way. So certainly using drugs in an incorrect way for long periods of time can definitely damage the brain and can cause symptoms of a mental illness potential. And sometimes acute use, like acute methamphetamine use, can cause like a psychosis almost in some patients. So you might confuse that with, is this patient having a schizophrenic exacerbation, or did they do meth? They can look similar sometimes if you don't know the social history. Oftentimes there are, and while we talked about socioeconomic status not being a huge factor, you have people all over the place, but they're associated with criminal and violent behavior and homelessness. Again, just depending on the person and what their approach, or what kind of limits they have, and what they're using their resources for. If they're spending all their money on drugs or alcohol or whatever and not taking care of themselves, they might resort to criminal or violent behavior if they run out of money and need to do something in order to get their next high. Economic, you have a fairly large healthcare burden with this. People come into the ER because they're found unconscious, or they're found walking around high, or they crashed their car, or they didn't report to work that day, or whatever it might be. But people oftentimes will get police called on them, so that involves the legal system, and then that links into the healthcare system, which links into EMS and ambulance rides, and then ER visits, and possibly visits to mental health units. And then you have people who might do a significant overdose on something. They might end up in an ICU, and all that is a massive burden on the healthcare system. So from an economic perspective, we talk about drugs of abuse from all these different areas, but it really does have a big burden on the healthcare system. So if we can help people get resources on the outpatient side of things, it does not only help that patient significantly, but it does help our systems in general, so we can divert resources to other areas of care. ID stuff. So I talked about needles and things like that. So bloodborne viruses, HIV, Hep C, Hep B. And then you have bacteremias, which can cause endocarditis. So if you have a young patient with endocarditis, it actually is somewhat common in IV drug abusers to get endocarditis. It's one of the more common presentations of endocarditis. Again, most risk is from sharing needles or using something that's odd. Like some people will think purification techniques. Like I can't remember who told me this, but I can't remember if I saw this or a friend told me this. I don't know. Anyway, we share stories with what comes into the ER. It's kind of like our favorite thing to do at work. And so somebody came in and they're injecting heroin, but they were putting like a cotton swab in the end of their needle to filter it. as they were injecting it. So what they were doing was injecting small particles of cotton into their bloodstream, and they ended up with this big, like, kind of embolus almost thing in their heart valves. They got endocarditis with this like other material in it too, so it was a really nasty like valve replacement type situation. So, and again, the point was we're sharing that story is that people will do things that they think might protect them, which also they just don't understand, again, proper sterile technique and what the best way to do inject something is. And so when it comes to like needle exchange programs like this picture I have here, those are really important for IV drug users to have access to. Unfortunately, at the end of the day, I kind of rationalize it that they're going to probably use drugs regardless. So if they're going to, and we don't have a direct way to help them in the immediate phase, obviously that would be ideal, but let's just assume some of them we can't reach right away, right? We can help them by at least offering them clean supplies. So if they're going to use drugs, they aren't going to, incur an infectious disease risk or end up in the hospital with endocarditis or end up on an HIV regimen for the rest of their life. Contributing factors to addiction. So these are things that contribute to a psychological addiction picture. So stress, physical, sexual abuse, witnessing violence, having peers who use drugs, drug availability, drug potency, higher dopamine response tends to be more psychologically addictive or cause people to crave the drug more. How to approach the topic. So again, the things I want to talk about very first and foremost, drug abuse is preventable and drug addiction is a treatable disease. So we do treat it just like any mental health disease. It's not easy to treat and there's a lot of challenges and there's not a lot of good. It's not like we can just, admit somebody to the hospital and give them a drug to help them with this. That's not how it works really. There's a lot of complicated brain chemistry that's at play here that we can try some things to treat, but at the end of the day, a lot of times it's going to become, rehab therapy, getting the person out of the situation they're in, not having them access to the product and allowing them to take some time to reevaluate what they're doing and hopefully get off the drug long enough where they can come clean for a certain amount of time. All right, let's talk about methods of delivery quick. If you can put a drug into your body any way, people have done it for abusing it. I mean, I think the most common way would be injecting and smoking, because when you think about what people are doing when the purpose of using a drug of abuse, right, is to alter one's mental status. So if we go back to our original thoughts here, the faster you get that drug into the body, the more impact you're going to have. So if you give yourself an injection, or you inhale it, that's going to be really fast onset. Taking something orally, you're going to experience that, but it's going to be slower. You could take like an extended release tablet or something and chew it, and then you'd get a more quick response. Snorting stuff, so using the nasal mucosa, that's going to get a pretty fast response as well. So the point is that we're using some, we obviously use things like inhalation and IV routes conventionally for different medications, but this becomes non-conventional as far as the medications they're using to administer this way. And the purpose is, right, to promote that, to get that high, to give the medication, get the drug into your system as fast as possible. This chart is maybe not the most, what am I trying to say? Reputable source, but I was reading some things. I've got some better charts on here to show you some stuff from actual literature, but I like this comparison. It shows sort of like the dopamine response and how methamphetamine does have just a massive dopamine response compared to some other ones, and I'll talk about how that works here in a second. But this is actually from a real journal and talks about the effects of drugs on dopamine release. So you can see like here's your dopamine in the pink here, and you have amphetamine with about almost 1,000 times percentage of basal release. And then you have compared to cocaine, compared to morphine, which really doesn't see a whole lot there, unless you get a bit of a higher dose. And then you have nicotine here too, which also has a pretty decent response. So you can see just from this, again, everything does affect the dopamine response and will increase what your basal release would be. And so the more dopamine response, the higher likelihood you are to feel. It's going to have a higher correlation to psychological addiction if you have a drug that's promoting much more dopamine response. Okay, let's talk about our different categories. First are opioids. Just some history of opioids. I think it's kind of fun to talk about. And these have been around forever. In the early 1800s, I think was the first started documented cases of opium addiction. People were getting addicted to opium. I don't know if it was coming over from into Europe from like the Eastern Asian countries, but it was prevalent and people were using it and becoming addicted to it. So they started to use morphine and somebody developed morphine and said, well, this is a pain reliever and it's a less addictive alternative to opium, which it wasn't. Of course, it's more addictive. And then by mid 1800s, people were addicted to morphine. So the drug company Bayer, which is still around today and has been around for a couple hundred years anyway, developed heroin, actually was a brand name, believe it or not, as a pain relieving, less addictive alternative to morphine. And of course, we all know what heroin is. Heroin was pulled from the market in the early 1900s because people were addicted to that. And eventually, oxycodone was developed using semi-synthetic techniques. It was actually developed pretty early. It wasn't really used widespread until the mid 1900s. And then it started to get combined with mild analgesics to promote less opioid use overall. So we've had this history where we've taken the natural product, which is opium, which is isolated from poppy plants. So poppy plants, before the flowers bloom, what the farmers will do to isolate the opium is they'll make cuts in the sides of the bulbs with razor blades, and this black stuff that oozes out is kind of like a latexy substance, and they actually scrape that off, and they do that individually, and that's how you harvest opium, and then you purify opium to make heroin, essentially. So it's actually kind of a labor-intensive process, and I'll talk about that in a second here with respect to like the Mexican cartels and what they're doing now with fentanyl. But that's the gist of it. In 1996, we had one of the first long-acting opioids on the market come out. That was Oxycontin, made by the infamous or notorious Purdue Pharmaceuticals. So, who's getting kind of slapped with all kinds of lawsuits right now. Basically, it's fine. Taken how many years later? We're almost 30 years later, and we're starting to realize that there were all these shady things that went on that they were, when they developed this drug, they said, well, people won't abuse this because it's long acting, and I think there were some noble intentions at some point here, but I also think the drug companies did some shady things with their marketing and undersold the addictive component of the product. And the problem with Oxycontin is it had really high doses per tablet. So some of the stuff designed for chronic pain use, like if we talk about a Percocet tablet, you've got 5 milligrams of oxycodone per tablet. You can have Oxycontin tablets that dose up to 80 milligrams a tablet. So people were taking these 80 milligram tablets, acquiring them illegally, crushing them, smoking them, snorting them, doing whatever. And then they were getting a huge rush. And the thing was that Oxycontin was essentially similar to heroin as far as its potency goes, but it was made by a drug company. So you knew you were actually getting what you got. If you got an 80 milligram tablet of Oxycontin, you knew you were getting 80 milligrams of Oxycontin. Whereas if you buy a bag of heroin from your drug dealer, it's like, well, is that batch the same as the one I got last week? I don't know. I guess we'll find out. So people were like, well, this is much better. So then people started switching, or people started abusing these drugs more frequently. And by 2010, it became the second most abused drug in the nation. So they reformulated. The government made Purdue Pharmaceuticals reformulate Oxycontin, into a tablet that's is supposed to be uncrushable. I think when there's a will, there's a way. People can figure out ways around that, or figure out ways to dissolve it, or whatever. And then the problem with being an oxycodone abuser was that oxycodone started to get really cracked down on the federal level. So DEA was much more in tune with some of this, and they were raiding pharmacies and pill mills and things like that, especially their large concentrations in Florida and California, where people were just churning out prescriptions for millions of tablets of oxycodone. And it was just a big, basically like a drug dealing ring, but they were doctors and pharmacists and other things like that involved who had legal access to get the products. So they cracked down a lot, made oxycodone a lot harder to get, and then the price went up on the black market quite significantly. So it turns out that heroin actually was fairly cheap. So it is true, and if you hear the rumors that people turn to heroin from abusing prescription oral opioids. That is a true situation that happened, and it ended up being one of the reasons why we're seeing heroines at such a high rate and injectable opioids in general being such prominently used, because they became so cheap to get switched, and people were switching because they're like, well, I can get just as high, if not higher. On it's just kind of in your head, I think, for the people in those situations, committing to the fact that you're injecting something instead of using an oral tablet, which maybe people were thinking, well, I'm just taking pills, it's not as bad as it really seems. But then once you start injecting heroin, it's a totally different ball game from a social stigma point of view, even though really at the end of the day it's the same thing. So anyway, heroin, what it is, it's metabolized quickly into morphine. I can't remember, I should have put it down, I don't have the exact molecular definition of what heroin is. So heroin was the Bayer brand name. It's still called that today. It is just an opioid. Again, it's just a fast onset. So its original product has a very fast onset, and then it gets really quickly metabolized into morphine. So basically, it's not all that different than morphine. Mu agonism results in euphoria, leading to subsequent dopamine response, just like any opioid. About 23% who use heroin will become somehow physically dependent on it if they don't become psychologically addicted to it as well. Receptor upregulation causes tolerance. Used IV is probably the most common way, but you can smoke or snort heroin. 50% of people who abuse heroin report abusing prescription opioids first. And lots of famous overdoses from heroin. Got Janis Joplin, Philip Seymour Hoffman, plenty of others as well. But it's a drug that is very potent, and if you use the wrong dose, or opioids in general, if you take too much of them, they are easy to overdose on, and you can stop your breathing completely if you use too much of one. Seizures have gone up substantially, just to show heroin. Heroin in its pure form is kind of a white powder, but there's kind of a notorious product called Mexican black tar heroin. I'm not sure if it's exclusively from Mexico, or that's just the name it got. But it's this kind of tarry substance, and it ends up leaving scarring in veins. So it's really hard on the vascular system. So people end up injecting in odd places, like maybe their neck or their feet, because they've blown out veins in their arm or other areas in the body. So opioids in general, if you don't use them in controlled environments in small doses, have a high potential for addiction, right? We know that. That's not pretty common sense now, and pretty common in today's culture, that people understand that there is an opioid crisis. We're finally starting to talk about it within the last few years, which is good. I think it's good to shed light on this, because it's been a big issue for a while, and I think people have been, again, it's sort of the stigma of being a drug user. You're a heroin addict. You don't have your life together. It's your fault. And really, there's a lot more at play here, and we have a system that was sort of set up for failure to begin with. So again, opioids, dangerous in overdose. Heroin gets cut to make money. So dealers will cut it with something like sugar, lactose, or possibly quinine. There's been cases of other dangerous chemicals. There's this stuff called levamisole, which I think is similar in appearance to heroin. I'm not sure why they cut it with that, but it's like a pesticide or something, like an anti-helminthic agent. I can't remember exactly. Anyway, it can cause agranulocytosis in some patients. So people will see like profound neutropenia, and they're like, what's happening with this person? And it's because they use some heroin with levamisole in it. Other things they cut it with, more commonly what we're seeing are fentanyl products. So you've got carfentanil, which we saw a rash of this recently in the cities. And what happens is there's some kind of a batch of quote unquote what's marketed as heroin. It's really not. It's actually a fentanyl or a fentanyl analog. You also have regular fentanyl too. And so what happens is these people take this thinking it's heroin. They take the same amount they think they're used to. And the people cutting it, honestly, aren't probably the best scientists on the planet. So are they doing it at a rate? Are they figuring out the potency and making sure there's exactly, okay, we used to put 2 grams of heroin in a bag. Got to make sure this carfentanil, and carfentanil is super potent. It's a tiny amount of product that could be the same potency as heroin. So it'd be really hard to do that without specific equipment. And I'm not saying drug cartels don't have access to like stuff like that, but they probably do. But the point is that you see lots of overdoses on this stuff because people get the dosing wrong, and it's so potent that they end up going into respiratory depression. So we saw I think this was maybe a couple of years ago, with carfentanil, but we saw a rash of carfentanil products coming through the cities, and we had, I think there was like 60 overdoses in a week that were reported in the Twin Cities area. More commonly, what we're seeing now is fentanyl, and interestingly enough, fentanyl is a lot cheaper to manufacture than heroin. So the trend right now is that fentanyl is coming in from the southern border, from Mexico, where it's being produced in cheaper, larger quantities for a lot less money, and they're selling it for the same amount of as if they were heroin. So we talked about how you make heroin. You have to grow poppies. You have to do all this stuff. For fentanyl, all you have to do is find a Chinese supplier. And this is, I'm not trying to rag on the Chinese, but this is where they're getting their chemicals from. This is all pretty well documented by the DEA. So they have some sort of Chinese supplier that provides them with the base chemicals to make fentanyl. They bring them into Mexico because the cartels control several large ports. They have some sort of a lab, kind of like, I think, Breaking Bad super lab, like that type of a thing, where they can ramp up production, and they make fentanyl. And fentanyl is so much more potent than heroin, and you end up with a product that's vastly more profitable. So that's what we're seeing right now, and that's why fentanyl is becoming kind of the new heroin. And we all, we talked about fentanyl briefly, but remember how potent fentanyl is. And whenever you're dealing with things in high potency, it's from a pharmaceutical perspective and therapeutic use. Like if you're in the OR and you're giving somebody fentanyl versus Dilaudid, as long as you dose it okay, it's not a big deal. But if you're not doing it properly, or if your batches are changing even slightly in variation, those little tiny variations between fentanyl batches can be a huge impact on the overall end user's experience, especially with respect to an overdose. So it's initially going to feel the same as heroin, but it's just going to cause a lot more profound sedation and respiratory depression, especially if the dosing's not correct. And again, it's very easy to get that off. So that's the problem we're seeing right now, and I don't think that's going to go away anytime soon, just because that seems to be the trend that illicit drug manufacturers and drug cartels are going. They're using more fentanyl and less heroin. All right. I've got some videos linked in here. If you guys want to watch them, you can. I'm not going to view them during this presentation. So treatment of overdose, not complicated. Remember we talked about naloxone and giving naloxone kits out to people. That's become, it was a controversial thing, I think, when this first came out. Like, we're giving out naloxone kits to people just so they can reverse their overdose. Is it encouraging them to overdose? It's been shown that it actually keeps people out of the emergency department and does save quite a few lives. So that's been a big recent development. In fact, I think in Minnesota, pharmacists can now give out naloxone kits as part of like a collaborative practice thing on the state level. So that's pretty cool. So you can get them almost anywhere. We give them out in our ER. So to families or friends of addicts, if you have access to the kit, you can possibly reverse an overdose and save your loved one's life in that situation. Treatment addiction to opioids is really difficult. We've talked about methadone and Suboxone programs during the opioid lecture. I'm not going to go into tons of detail on that anymore. There's not a definitive treatment time. Some people would be on methadone for life. Like they always take it because they always have that baseline addiction that they can't kick, that craving, and methadone suppresses it. I'll just say that Suboxone, there's some studies that show that Suboxone's better tolerated for younger people, and younger people tend to have better success on it as an overall program, just because people think of methadone programs as having this big stigma associated with them. With methadone, you have to go to a clinic every day usually and get your doses. Some people get take-home doses, but they have to be really reliable and on it for quite a while. Suboxone you can get from a normal pharmacy. So you could get that at a CVS or whatever. And there's a lot less stigma with picking up a drug there and taking it. No one really knows what exactly you're taking, except for the person that filled it. And they're bound by law not to tell anyone, right? So there's a lot more success, I think, with that type of a program than some of our methadone clinics. So the methadone clinics definitely have a role, because you do ensure that person is coming and getting it regularly. Heroin and opioids are produced throughout the world. Mostly we've got in Mexico. That's probably the biggest source of stuff coming into the U.S. just because of its proximity. You've got a large amount of production in Pakistan and Afghanistan, and then in Southeast Asia too, Vietnam, Thailand, and that area. And just trafficking routes, in case you're curious. Again, I don't want to spend a ton of time on this, but I kind of like this type of stuff, so that's just for me more or less than anyone else, unless you like to learn about this stuff too. Prescription opioids. So we talked about oxycodone already, and this big crisis that we had where people were just churning out these products. I think there's just a news article I read the other day where there's some they discovered that some pharmacy in the town of like 1,500 people received like millions of pills of oxycodone over the last few years. So stuff like this happens, unfortunately. For teenagers and young people, the access to these products are really good. I mean, how many people even in the class, or I know myself personally, I have some, my wife had a surgery a couple of years ago and she has some Percocet left over from it. Why we don't get rid of it, I don't know. It's kind of like, well, you never know if you're going to like, I don't know, injure yourself severely and maybe want something for pain before like an ambulance gets there. I don't know, or who knows what you might need. But honestly, the idea of just having them sitting around the house, especially with younger children who might be more prone to not younger children, well, younger children who might be more prone to taking something without thinking about it. Certainly that's a problem. But for teenage people who are more impulsive to try something they find and see if they like it, that could certainly be an issue. So I just encourage people to use caution with keeping these things around their house. There are a lot of there are a lot of take back programs that are available. And in fact, the Hennepin County program has a really cool system set up where you can go and dispose of drugs in I think most of the police stations, or there's a number of locations. Anyway, I'll talk about that next week. I've got a slide on that specifically for drug disposal and stuff like that, because that's a really common question that comes up. So anyway, it's a big deal. The prescription opioids are huge, and we're seeing a lot more, again, media attention and national attention on this. Fentanyl, I talked about that getting cut into heroin. It also, people seem to be taking it orally now too. I mean, Prince died from fentanyl and he was taking pills of it, which is really strange because that's not a pharmaceutical product. So I'm not sure where, again, he got that. And he obviously obtained it illegally. How he, again, what exactly happened or who sold it to him was never really found out or investigated. So again, you're seeing stuff like that come up here and there where we're seeing this isn't going away anytime soon. And just to show you opioid deaths, so what we're having is kind of the trend over the last several years. And you've got commonly prescribed opioids kind of staying somewhat steady but going up, flatlining a little bit. Heroin is really low and not seeing a lot. And then 2010, again, remember when around that time was when oxycodone became really hard to get. So you have heroin just spiking because people were turning to it. And then kind of in the early 20-teens, you have this huge influx in people taking fentanyl, tramadol, other illicitly manufactured synthetic opioids. So fentanyl, again, being one of the, fentanyl and carfentanil and things like that being one of the biggest sources of this. So this is really scary to see this trend going up so frequently, and that's incredibly exponential when we're looking at it that way. So when's that going to stop? How are we going to help that? And what kind of trends are we going to see in the future? It just depends on what happens. So we'll keep watching these things, but that's just what I've got to show you for now. Okay, stimulants, talk about cocaine. So cocaine's isolated from leaves of the cocoa plant. It's produced in South America. Colombia, Peru, and Bolivia are the only places in the world that you can grow these leaves, believe it or not. The U.S. is the largest customer. And originally, they discovered the stimulant effects by, I think the native populations used to chew the leaves and still do maybe a little bit. And it's kind of like maybe getting a little bit of a caffeine boost from what I understand. I had some friends in pharmacy school that went and hiked the Inca Trail and they said they chewed coca leaves while they were doing it because the guides told them to. And they're like, well, let's try it. And so they ended up with, they were like, yeah, it's kind of like drinking tea, almost like a little bit of a caffeine boost, but nothing really more than that. Synthetic cocaine is really hard to make in a laboratory setting, so it's rarely done. So that's why we still make cocaine using kind of the old school methods. And extracting from plants is the most cost-effective method still available. It's not a nice process. I think most of us have probably seen Narcos on Netflix or something similar like that. There's tons of different movies out there about the cocaine trade. It's interesting from a historical perspective, but it's certainly not pleasant. There's lots of abuse of families and farmers and things like that, where they force people into farming this product for them and isolating it. So basically, to do this, you pick the coca leaves and then you mix them with chemicals and gas and water and other things to create a paste that you dry. and then you would sell at that point. So children, families again put into this by force by drug cartels. Lots of movies, I think, either glamorizing cocaine, and then all the movies are the same, right? Every person who makes a lot of money on cocaine always goes down in a blaze of glory, right? So that's kind of the moral of the story. Pharmacology. So what cocaine does, it inhibits reuptake of serotonin, norepinephrine, and dopamine. Dopamine transmitter proteins are blocked, and it blocks sodium channels. So it also has that topical anesthetic effect. So cocaine isn't a C1; it's actually a C2. You can use. We actually have cocaine that we use topically for nosebleeds in the ER. It comes as a solution. So, but as a drug of abuse, it's much different. You're inhaling it and it's getting absorbed, or you're not inhaling it. You're snorting it and it's getting absorbed in the mucosal, and then it's going into the brain pretty quickly. So you get a short-term euphoria, energy, talkativeness. It can change hemodynamics. You get blood pressure and heart rate increases. Your powdered form is pure cocaine, could be cut with something else potentially too. You can't really smoke cocaine. It's got a really high smoke point or melting point, so apparently you can't do that. So what they do is they process cocaine into a crystalline rock. It's called freebase cocaine. It's actually a more pure form than the powdered version, even though it's funny because crack itself is, I think, associated as a cheaper drug or with people of more low socioeconomic status, and cocaine powder is kind of associated with high economic status, but crack cocaine actually takes more processing than cocaine powder does. So anyway, crack refers to the sound it makes when it's smoke. People think it's maybe a more addictive, faster high, but it's probably just more the injection. People route of administration. People tend to either smoke or inject crack cocaine versus the powdered form, which is snorted, which would be a little bit more of a delayed onset than something injected or inhaled. Some pictures of people doing cocaine. So nasal mucosa, because cocaine has topical anesthetic properties, it also has vasoconstrictive properties. Over time, it can really be harmful on the nasal mucosa, and people can end up with a lot of damage. Crack pipes can be really hot. Any type of inhalation pipes, so that wouldn't just apply to crack, but smoking methamphetamine or anything else like that, people can burn. And also, the product is actually fairly usually it's fairly alkaline, so people can end up with chemical burns in addition to physical burns on their lips and mouth, and it can also have some negative effects on somebody's teeth as well, and can kind of dry your mouth out and things like that. So bad dentition is definitely possible with cocaine use. Acute cocaine toxicity, second to alcohol when looking at drug-related ED visits. So people get cardiac problems with these. So usually they come in on an arrhythmia. Cocaine's a sodium channel blocker, so it is pro-arrhythmic, especially in high doses. And it does cause coronary vasoconstriction too, and some negative inotropic effects as well. So having a heart attack type picture isn't totally uncommon with cocaine. You can also get central nervous system excitation to the point where you have seizures and possibly deficits even. You don't really treat this any other way. You treat it basically like a standard cardiac arrest situation. We talked about managing the blood pressure in the emergency medicine lecture, so I'll refer back to that one. Other complications, I talked about all this stuff already. I'm not really going to go through it again. Treatment, acute treatment. Benzodiazepines are good for agitated patients on cocaine. Remember, don't use beta blockers alone because you'll shunt all your cocaine to your alpha and then you'll cause significant restriction. Otherwise, you're just going to use supportive care. Chronic withdrawal is usually pretty tolerable for cocaine. Patients usually allowed to sleep and eat in a controlled environment. If they get agitated, a little bit of benzodiazepines can be helpful. There's not really any medications to help with cocaine dependence consistently. There's been trials of disulfiram, topiramate, tiagabine, modafinil. Nothing's really been shown to work great for cocaine long-term treatment as far as medications go. All right, the next stimulant, methamphetamine. So most potent drug when it comes to dopamine response. It's highly addictive, and I think we all know, based on kind of the popularization of methamphetamine production in Breaking Bad, if you've seen that show, but produced throughout the country and world. There's lots of laboratories out there. I think people think of meth labs as like in somebody's basement where they're using Sudafed to do that, but more high functioning labs and like super labs like you saw in Breaking Bad do exist. They exist in maybe in the United States, but certainly in places like Mexico. where the cartels have a lot more free reign to do what they want. Methamphetamine production has skyrocketed in Asia as well. It seems to be, I was just reading an article about that the other day about how the production and the seizures have just gone through the roof over there. So this is definitely something that's popular still. I think people think of meth as maybe like a 90s drug, or it's not around anymore, but certainly it's fairly prevalent in today's society where it's available, it's relatively cheap, and people are using it frequently. This is not really a recent arrest anymore, but I just think the cartel stuff is interesting too. So again, you can go to, even though it's not entirely historically accurate, I'll refer people who want to know more about this to the Netflix show Narcos Mexico, which is kind of an interesting way where they started the cartels. And the cartels are super complicated. They're always kind of competing with each other. But the point is that there's a lot of violence associated. If you look at the top murder rates in the world, most of them are in Mexican cities, because of the cartel violence there, and some of them are in really touristy areas too. I mean, just outside of the touristy parts, you'll have fairly high murder rates. Unfortunately, they don't seem to impact the tourist industry a ton, but it's still something that definitely spills onto our border a little bit because of our proximity, and certainly we're their primary market, right? So they're trying to move drugs into our border because they want to sell them to us, and that's where they're getting their money from. So cartels have bases in various cities. So again, I'm not going to go into that a lot, but there's some cool articles in the Star Tribune a while ago about kind of the cartel wars just on our local turf here, and basically how there were some Mexican cartels based in South St. Paul, and some California-based cartels out of North Minneapolis, and they're kind of competing, and we were in the middle of this gang war basically between the two sides of the city. And most people are probably not super aware of that, so it's just interesting how far-reaching the cartel's influences are, and where they're pushing drugs through, and what kinds of hubs they're using, and all the types of things like that. So anyway, not going to talk much more than that, but other than to mention it. All right, so the pharmacology of methamphetamine causes and releases and blocks reuptake of dopamine, norepinephrine, and serotonin. So the interesting thing of this is when you compare it to cocaine, it just does a lot more. It's a lot more potent, and it's basically, I think of this drug as forcing neurotransmitters out of a neuron. So you're basically blasting the neuron apart. You're causing a huge release of neurotransmitters at one time. People get increased energy, alertness, euphoria, sympathetic activation, decreased sleep, increased sexuality. Up to 25% will experience temporary psychosis. So this is, again, a really common thing with methamphetamine. Methamphetamine is directly neurotoxic as well. It causes a lot of, I think I have some other, maybe I have something else on that here too. No, that's it. Well, anyway, it's directly neurotoxic. And so not only can you get temporary psychosis, but you can actually get permanent psychosis type symptoms. So people who have schizophrenia sometimes, or schizophrenic-like symptoms, sometimes developed it from long-term methamphetamine use. It's definitely possible. Other issues you have, Meth Mouth, I think, was more of an ad campaign to get people to not use meth, but certainly it's possible. The compound you're inhaling is caustic to the gums and the teeth, and so you can end up, and people who use meth regularly, not to stereotype, but probably don't necessarily have the best oral hygiene, and they also tend to grind their teeth due to some of the side effects of the product they're using. Again, probably exaggerated to some degree. Same with the whole meth mites thing, where people end up like scratching their faces off. It's certainly possible, and in fact, some of the byproducts in methamphetamine manufacturing can cause like a histaminic component or an irritation in the skin. And so sometimes people do scratch themselves and cause bleeding and sores like that. So it is possible, but again, probably a little bit exaggerated in the advertisement campaigns. And then anorexia. People don't tend to eat a lot when they take stimulants. Stimulants for a long time have been shown to decrease appetite. Sudafed decreases appetite. The stimulants we talked about for ADD and ADHD decrease appetite, and this is no different here. So meth use has a couple things to talk about. Finally, benders. People who use methamphetamine tend to go on a couple of days where they use high use, and they'll kind of just continue bumping themselves on methamphetamine, and then they might go a few days or a couple of weeks without using, and then repeat it. The treatment is really difficult, so there's no and non-completion of treatment programs associated with the following things here. So it's hard with methamphetamine because there's not really a lot of medications that have been studied for it. It's hard because the treatment programs out there have been shown to be less effective for methamphetamine use than some other drugs of abuse use. It's just a very difficult thing to treat in a lot of patients. Overdose, basically just supportive care. Antipsychotics, benzodiazepines for the agitation. Chronic, usually you're looking at some sort of a long-term rehabilitative program. MDMA or ecstasy, that's the compound of MDMA. It's structurally similar to methamphetamine, but the effects are pretty much quite different. It induces euphoria, intimacy, diminished anxiety, mildly psychedelic sexual arousal, and disinhibition. It's a popular club drug because of it enhances the illusion of surreal audio visuals and lights and things like that. There's no accepted medicinal use, so ecstasy is a C1. However, this is one of those drugs that was actually originally developed for psychiatric conditions. In fact, I think it's been studied in PTSD. It's something that people thought might work. The problem is that when it was originally developed, people started abusing it right away, and it ended up kind of ruining it for any future research. So again, C1 drugs are really hard to get funding dollars for because they're so restricted. So studying it is tricky, and that's just where we're at. But we might see some use in controlled amounts with this particular compound, or a compound maybe that works somewhat like it. It's somewhat similar to your standard amphetamines where it affects dopamine, norepinephrine, and serotonin, but the focus is mostly on serotonin. It tends to have a really big release and prevents reuptake of serotonin. I think this drug was, maybe this is kind of dating me a little bit, but they called this Molly for a while. I don't know if people still do or not, but there's this discussion on whether or not there's like a pure form of MDMA versus adulterated, and Molly being like the pure MDMA and ecstasy being adulterated. I don't know enough about this to give you a firm opinion on this, but one of the things I do know is that drugs in general get adulterated, especially when they're on the black market. So people who are using MDMA or think they are, who knows what they're actually getting. They might be getting opioids, they might be getting some sort of a methamphetamine product or some sort of a synthetic drug as well. You really don't know. The side effects of MDMA, hypertension, tachycardia, and hyperthermia. So usually people get really thirsty. And serotonin syndrome is possible too, especially if they're on another serotonergic agent because it's so strongly serotonergic. Cardiovascular toxicity is rare, but it can happen. And hepatotoxicity is also rare, but can happen. Withdrawal, depression is the most common thing that you're going to see with people withdrawing from MDMA. So the body can't sustain that type of serotonin levels. So if people use ecstasy regularly, they're going to feel really crummy when they're off of it. And so that leads to this cycle where they're almost using it on a daily basis because they'll feel depressed if they stop taking it, which makes it really hard to treat and get people off of it long term. Social acceptance. I feel like MDMA and ecstasy out of a lot of the drugs of abuse are more socially acceptable as safe or just for fun or whatever, but they can have pretty significant long-term consequences, especially on mental health of patients after using them for extended periods of time. All right, let's talk about a couple other drugs. Marijuana, I'm not going to spend a lot of time on this because you guys all did the forum last semester. If you want more information on marijuana, again, I said this in my summary last semester, but your colleagues did a lot of really great research on this, so I'd recommend, if you haven't, just to go through and read some of the things people reported on, because again, I learned some things, and I think you guys probably will too. Just to touch briefly on it, obviously marijuana is the most common illicit substance out there. It's not even illicit in a lot of states anymore. However, it still technically is on the federal level, which makes it super confusing. So basically, medical or recreational marijuana is not regulated by the U.S. government. It's illegal federally, regardless of state laws. However, President Obama said that he didn't really care if the states wanted to do it. He wouldn't pursue any issues federally. Trump hasn't really gone after it either, although there's some threats here or there that come up. I don't think it's a big priority of his at this point, but we'll see what happens. It's currently Schedule 1, which again means it's difficult for institutions to use for research, and it puts providers in a very tricky spot because if you don't prescribe it, your patient might want it, but you might not want to risk your license because technically what you're doing is illegal on a federal level. So anyway, there's all types of stuff like that, and you guys did some research into this already, so I'm not going to rehash a ton of it other than to say it's obviously a very, very hot button political issue. What is marijuana, though? To talk about it from just a pharmaceutical perspective, it's an active. It does have two active components: the tetrahydrocannabinol and the cannabidiol. So THC agonize activity at cannabinoid receptors. So your body has two subtypes of cannabinoid receptors that we know of: CB1 and CB2. CB1 has CNS effects, so these are responsible for the psychoactivity of marijuana, and CB2 has immune system related effects. It really isn't related to the drug's abuse potential. Cannabidiol, CBD, indirectly antagonizes CB receptors, which is kind of odd. You wouldn't know we don't know exactly why this does certain things therapeutically. Might increase receptor density, so you can utilize CB receptors more frequently. It's thought to be more medically beneficial. So pretty much any product that's looking at a medical benefit is probably looking more at cannabidiol, high cannabidiol concentration. So you'll see like, I don't know, 70% CBD, 25% THC, or 99% CBD, or whatever it might be, if you're looking at the dispensaries. So that's pretty common for, again, most of the medical conditions we're looking at treating are CBD related. There's a couple that THC is preferred for, but most of them are CBD products. Dronabinol is Marinol, which is a product that is a synthetic version of THC. It's actually a C3, so it's kind of funny. Marijuana itself is a C1, but if you isolate THC and make it in a lab synthetically, it becomes a C3 drug. I don't know. It's kind of strange, but that's where we're at. So Marinol is an oral product that's been used for mostly appetite stimulation in cancer and HIV patients historically. Most of the studies looking at the therapeutic benefits of cannabis have come out of studies from dronabinol. So oftentimes they're like, well, these people with Crohn's disease got a response from dronabinol, so we probably think that medical marijuana might be effective for them. So that's where a lot of that evidence comes from. It doesn't necessarily come from doing studies on actual purified CBD products. That's still very early in research, or very limited in its research. Cannabis use effects: you get mildly euphoric, pleasurable feeling. Some people might get a lot of anxiety and panic on it, and then so they kind of get the opposite of what they might have intended to do when they smoked weed or however they ingested it. Cognition and psychomotor slowing, decreased reaction time, impaired memory and concentration. Certainly operating a vehicle on cannabis, whether it's legal or not, is not recommended, and you'd get the same type of legal impact as you would if you drove drunk in most states that have legalized it recreationally. Physical effects: increased appetite, tachycardia, increased blood pressure, although mild. The hemodynamic effects aren't usually substantial. Dry mouth and eyes, which is the red eye, common kind of thing, and then hyperemesis as well. Hyperemesis is something that we really, when I first started practicing in the ER, 8 years ago or so, I never saw this. I'd never heard of it. I didn't know anyone who had heard of this. Maybe it existed in places other than Minnesota, but again, I'd never seen it. I never saw anyone come into the ER with it. Fast forward to like 2 years ago, and now we see probably a couple cases a week of hyperemesis from cannabis use. And I don't know if it's because people are vaping the concentrated products more, and they're getting more of a dose than they used to. But it can have this effect where people get just this continual nauseous feeling and vomiting feeling they can't get rid of. The antiemetics don't touch it very well. You can try them. They just don't seem to do anything. Basically, you have to wait till it gets out of the person's system. Having somebody, I've had at least a handful of patients in the ER sitting kind of across the desk from me in their room, just retching constantly, which is something I'll never really forget. So there's a couple things you can do for it with respect to cannabis. You can give hot showers can help, actually, and also something called topical capsaicin, which I think we talked about during osteoarthritis briefly, but it's used as an arthritis pain reliever cream that can actually work to help with that, the nausea too. So it's a different way we treat it overall, but you can use conventional products too. Some of the antipsychotics actually have been shown to maybe be better, like olanzapine and haloperidol for hyperemesis associated with cannabis use. So just a different thing. If you work in ER urgent care, you're going to see it. It's just a lot more common now than it used to ever be. For using marijuana, most people inhale it. So smoking, I've got Miley Cyrus here hitting a bong for your viewing entertainment there. You can ingest marijuana as well. So edibles, of course, it's a pretty common term nowadays, especially with recreational use. And that's a way to get it orally that's going to slow the release of it if you don't want to smoke something but still want to ingest it. So most people, excuse me, Most places that are allowing medicinal marijuana are looking at edible products as opposed to inhaled smokable products, or possibly vaporized solutions that are less likely to cause lung cancer long term. 'Cause even though marijuana smoking isn't, we don't have as definitive evidence compared to cigarette smoking, you're still inhaling smoke, and so the odds of it being good for your lungs are pretty slim. Maybe it's better for you than cigarette smoking. I don't know, but it's probably marginal at best. So anyway, if you're going to look at something medically, you're probably going to look at something that's not a smoked form. You're going to look at, again, inhaling or possibly vaporizing the product. Long-term use, just like any drug of abuse, you do lose pleasurable effects after time. You can get cognitive impairment. Mental health disorders in young adults is a link to. Now, that's, some of this is a little bit controversial, and I think all of this needs more evidence and more availability. But the point is that there are some concerns out there that using marijuana or cannabis, especially at a young age in your teenage years, does have some impact on your mental health long term, and can be linked to some mental health disorders for young adults after they've been using it for several years. Withdrawal, people usually don't withdraw from cannabis. And if they use a lot, they might feel like mildly uncomfortable, but they're probably just going to want to smoke again to get back to their baseline, if you will. Mental illness, again, psychosis with high use is possible. If you take a ton of it or like use a lot of concentrated product, you could get some mild psychosis. Paranoia, and certainly symptoms associated with paranoia, and maybe even delusions and severe anxiety are possible. Car accidents, use doubles risk of getting in an accident, so that's probably not a surprise to anyone. Potency, increase in community, significantly higher. Addictive, this is always a question that I think is interesting to ask on whether or not marijuana is addictive. I think this is an ongoing debate on its addictive potential. I think it definitely, based on literature, is addictive. People do get psychologically addicted to it. However, the question is it any more addictive than alcohol or other things like that? It's probably not. But does that mean that it's still okay to use? I don't know. There's always these debates on. We just had a state legislature debate on legalizing marijuana, and one of the ER docs I actually work with went and testified in favor of it. And one of his big things was like, I see, the worst problems I see in my ER are people who have abused alcohol long term, or have eaten, fast food diets for their life and now have heart failure and all this kind of stuff. And like, you've kind of got a point there, but on the other side, it's like, well, do we really need another substance, legal, recreational, where people can, cause damage to themselves? I mean, I don't know. I'm not trying to argue for or against it, because that's not the point of this class or this thing, but it's an interesting ethical debate, and it's certainly not one that's going away anytime soon. So as a provider and somebody who's in healthcare, you're going to get pulled into these conversations. So I would just think about it. That's all I really say. All right, social impact, lower life satisfaction, poorer mental health, physical health, correlation to increased rates of dropping out of school or losing a job. Gateway drug, actually there is pretty decent evidence. I know this is kind of like a term that makes me sound like a dare person doing a presentation, but it is actually proven that people who use marijuana are more likely to use other drugs like cocaine or opioids than people who don't. And if you compare them to people who use alcohol, yes, people who use alcohol can abuse alcohol, and alcohol abuse is a rampant problem in our society, don't get me wrong. But if you compare them directly to people who abuse alcohol don't usually go on to abuse other drugs. People who abuse marijuana tend to be more likely, not that everyone is, and it's still a small percentage, but it is technically a gateway drug, and there is good evidence to support that. All right, cannabis legal issues. Recreational legalizing has a bunch of things associated with it. And again, I'll kind of refer back to that forum post, because that was really where all this came from, what you guys talked about and researched. Ketamine. Ketamine, I don't know if anyone really abuses ketamine anymore. We've talked about ketamine a few times on and off and how it's used. It does cause hallucinations, but sometimes they aren't pleasant in a dissociative state. It is an anesthetic agent, so again, I'm not going to talk about it more than that. GHB and Rohypnol, or Flunitrazepam, are these really, really short-acting products that kind of cause either severe short-term sedation type situations or possibly amnesic components. So I think of like Rohypnol or Flunitrazepam as being like the roofie, quote unquote. It's a potent, strong, really short-acting benzodiazepine. generally grouped into club drugs. So there's synthetic variants, and again, this is where you lump ecstasy into this, and what you're getting if you're buying something that's marketed as one of these by a drug dealer, you don't really know exactly what you're going to getting, or maybe it's none of these and it's some kind of synthetic modified version. Unfortunately, these are heavily associated with date rape, so getting somebody to pass out or forget, and taking advantage of them. They are intoxicating. They're very. Flunitrazepam is essentially benzodiazepine, so that's what you're getting here. It's just a very potent, short-acting one. Other hallucinogenics, you've got PCP. I don't know if people really use PCP all that much anymore. I think it gets cut into some stuff occasionally, and you see spikes of it here and there throughout the country. Dextromethorphan, you can take a lot of this. It's a cough. Obviously, it's just over-the-counter cough syrup. You drink a lot, it does cause hallucinations. LSD activates serotonin receptors. I kind of think of this similar effect pharmacologically to ecstasy, but it's more selective, and it doesn't really have the effects of ecstasy, other than that maybe some induced psychosis possibly, or you have this hallucination property, but it does kind of have a similar component to that. This is another one that people are like, oh, they're doing research into LSD or LSD analogs to see if there's more mental health benefits, and maybe we'll see some of that. Interestingly enough, if you have SSRIs on board, that tends to reduce the effectiveness of LSD. Okay, synthetics. So synthetics are a big thing that have seen for the last decade or so. There's two, I think, major classes of them, but there's tons, so it's really not able to spend a lot of time on them without getting way into the weeds. Synthetic marijuana was first started as K2 and spice. It was originally illegal because the government no one really knew what it was. And head shops were selling it, smoke shops were selling it at gas stations, and you can buy it on the internet. And they were saying, this is something that isn't for human consumption. It's incense or whatever. I don't know, whatever they were marketing it as, but people are smoking it. And the idea was you would have a synthetic attempt to mimic marijuana's effects. However, the interesting part about this is that it actually acts almost nothing like marijuana. So it's more like a stimulant, and people get really toxic effects from it too. But some people were like, well, it's legal, so I might as well take it. I'm like, yeah, but who knows what's in there? And I don't think anyone really did. And again, it still goes. Lots of stuff gets marketed like this nowadays. What is it? It's probably some odd combination of synthetic stimulants that somebody probably concocted at some point. Bath salts, again, not actually bath salts, right? They look like bath salts. That's why they're called that. And they might be marketed like, oh, this is a bath salt. Don't use this for human consumption, but it's actually a drug you're supposed to inhale. So it's a synthetic derivative of cathinone, which is an amphetamine stimulant found in the khat plant. Its primary effect is dopamine release, just like any stimulant. Side effects would be similar to methamphetamine. Stimulants are a really mixed bag. They're usually really toxic, and they have lots of odd side effects. The psychotic-related effects from these tend to be fairly substantial if they do occur. This next picture is kind of graphic, so sorry. But this is this guy in Miami who was high on bath salts and ended up, chewing the face off of this guy. It kind of got like a zombie apocalypse type thing. The bath salts turn people into these, zombies or cannibals or whatever you want to have it. But certainly the synthetics have a very mixed bag of effects, and you can see some very odd behavior on them compared to your more traditional or standard drugs of abuse. Crocodile is something called desomorphine. It's compared to morphine, but it's a more toxic, more potent version. It's really popular in Russia. I think we've seen some spillover to the States. It's a clandestine production type thing where you start with codeine and you basically mix it with some byproducts and eventually get this desomorphine. It's really acidic. You can Google the images at your own risk. They're pretty nasty. It causes a lot of skin necrosis, which is why I think that's why it's called crocodile, because it gives you kind of like scaly skin where you've been injecting it, which is a great marketing campaign, right? What about mixing substances? Happens a lot. Alcohol gets mixed with a lot of the drugs. Most people use both, or will combine alcohol with something. Usually compounds to toxic effects. Some cases much more deadly. So, for example, if you combine certain things like heroin and cocaine is called a speedball, or any opioid and a stimulant would be the similar effect. So it doesn't have to be heroin and cocaine. But what happens is you suppress some of the side effects. So because you've got a stimulant on board, you might believe you have a higher tolerance because the cocaine or the stimulant is counteracting your respiratory depression effects from the opioid. And then the stimulant wears off and you still have some opioids on board. You might have taken more opioids because you felt like you could, because you weren't getting any, maybe you weren't getting as much of an effect, or you weren't getting any side effects, but you're feeling high and you wanted to get higher or whatever it might be. But just, I don't think this is used as much anymore, but there are some very famous overdoses. Chris Farley, River Phoenix, John Belushi all overdosed on that combination. Cocaethylene is something that if you combine cocaine and ethanol or alcohol, produces longer durations of effects. It's a mediary. It's actually a compound called cocaethylene, and it's got higher cardiotoxicity too. So that combination can produce a deadly cocktail of heart-related effects. Other prescription drug abuse. Here's my funny picture of a farm party. I don't know if kids really do this. I kind of hope they don't, but I'm sure it does happen sometimes where you mix a bunch of drugs together and just take them and see what happens. It's a terrible idea, obviously. Who knows what you're taking? You could take somebody's hydrochlorothiazide and just have to pee a lot. That would be probably a best case scenario, right? And then things like promethazine with codeine syrup. I kind of thought this faded away, but apparently, like, people called this is going to make me sound really stupid, but people call this lean. I think is now what the rappers call it. I don't know. Again, like, I'm probably sounding like an idiot when I say this, but I think it's still pretty prevalent in culture. And actually, my boss's neighbor. I know this sounds like a stupid story too, but anyway, my boss's neighbor is either works for the FBI or DEA, and he was talking about how they have codeine is actually one of the biggest diversion risks right now, and people are abusing codeine quite frequently, which is kind of funny because it's such a low potency opioid that it's almost like, do people really get much of an effect from codeine? I don't know. I mean, it's like a tenth of the potency of morphine, so I don't know really what people are getting out of codeine, but apparently it's a popular diversion option right now. So there you have it. Decriminalization. There's a lot of discussions about this, and I just think it's interesting to consider that we jail a lot of people for drug use and drug possession. The question is should we be doing that? Should we be focusing more resources on treatment programs, which is probably the right answer, and should we be focusing more of our law enforcement resources on preventing drugs from getting the bigger seizures of drugs, getting stuff off the streets more so than focusing on the end user. So that's always an interesting debate that comes up. Drug packers is something that can occur. People who are either getting drugs strapped to their body, which would be really hard to get through an airport now, but some people swallow. So these are like usually wrapped up in either small balloons or like a condom, and then they're swallowed. So you can see these images with the little packages all throughout the thing. And this is somebody who unfortunately died, and you can see all these stuck in their stomach. So people will ingest a whole bunch of them, get on an airplane, and then come over and wait till they defecate them out. Now, if one of these things breaks open and that's a bunch of cocaine or whatever it is, that gets absorbed into the system, and then the person probably dies because it's such a huge amount of product. Recovery and permanent damage. So recovery is really difficult and expensive. Like, for example, a stint at Hazelden, which is kind of a famous rehab center in Minnesota here, is $20,000 to $30,000 plus for one course of residential treatment. So it's not cheap. Sometimes insurances may pay for some of it, depending on what insurance you have. But a lot of times people are paying out of pocket for this stuff. Pharmacologic options, as we talked about today, there's really not a lot that's proven. There's barely anything that works. The one thing I didn't really talk about a ton is naltrexone, which I think is getting used a lot more. So naltrexone, oops, I spelled that wrong. Naltrexone is a long-acting version of naloxone, basically, right? It's an opioid antagonist, but the idea is that it might antagonize part of the body's natural pleasure pathways, and I think they're using this a lot more. We talked about it a little bit with respect to alcohol addiction and alcohol use, but I think they're using it a lot more in other types of abuses too. And the idea is that, well, it doesn't really hurt, so maybe we'll try it and see if it has any benefit. It's getting a lot more popular just to try, even though I think we're still off on the evidence. We don't really have evidence that it does all that much for other things other than opioid use disorder and possibly alcohol use alcohol use disorder. Permanent damage. A lot of people will be affected very differently. A vast majority of the population could take a drug of abuse and be fine and not get addicted to it and move on with their life. But there's going to be large chunks of people also that have problems. They get physiologically addicted to it. They might have a severe side effect from it. They might get some kind of a toxic effect, like a psychosis or something like that from taking it. So there are certainly risks, but a lot of the population could use it and not be affected by it. So again, different people, different effects. Got to treat everyone a little bit differently. Sports-related stuff. I didn't really talk about this. The testosterone and EPO and things like that. I think that's a whole other topic, and I think I touched on that during the men's health lecture just a little bit too. So I won't talk about that now, but certainly that's a whole other thing to think about as well. So anyway, that's that lecture. Again, what I'll ask you about are the kind of the major drugs of abuse. We talked about how they work, if there are any treatments for them, either immediate or acute, or if there is a long-term use for any type of drug to help with long-term prevention of abuse, that would be something too. But otherwise, it's going to be pretty basic questions. So let me know if you guys have any questions about this stuff, and we'll see you in class on Monday.